Society, I think, sorry, let me just, there's a pop-up that came up of recording. So it's the alert to me. Yeah, so I have been to your society once, and if I correctly remember, it was in Carshalton, in one place. I was, we'd all gathered, and I gave a certain talk. So pleasure to be here again, and I'm going to talk the links between diabetes, heart disease, and the rhythm problems. So we know, there are quite a few rhythm disturbances which we encounter in a person with diabetes, but we shouldn't look at diabetes as a single entity. And let me just start sharing my slides actually. So if you just enable sharing, please, for me.
Shared work now.
Okay. Right. Okay. Can you see my slide? Yeah. Let's move this box up here. Okay. You can all see my screen? Yeah. Okay, so I'm going to talk about, that's how the heart looks like, by the way. Not quite. That's how it actually looks like. So these are, I know you are recording, so these are pictures I have just for the purpose of education. I've lifted from.
Sorry, Abhay. If you went into presentation mode, we cannot see the presentation mode. We are still on slide 1.
You cannot see the presentation mode?
No, you probably have to reshare.
So how do we do that? Let's do a reshare. Let's do a reshare.
That happens to me all the time at work. So.
Yeah, usually Zoom is quite good. It happens
better than Teams.
Often in MS Teams.
Teams, correct, yes.
Lots of messages coming on the screen for whatever reason. I don't know, there's a message coming, screen sharing has failed to start. Not sure why.
No, not sure.
Let me close this again and then restart. Can you see my screen now?
Yes, we can. Yeah.
Okay.
And we're on slide 1.
What about? Oh, it's not moving actually for whatever reason. Yeah. Can you see the second slide?
Slide 3, in fact, now.
Yeah. Okay. Fine.
Yep.
So let's see if I go on PowerPoint. How about now? Can you please see the next slide?
I think the presentation mode is failing us. So if you want to just stay on the, it's fine if we don't see it.
Yeah, I think I'll go back to the original mode. That you can see this now.
Yes, and
I think it's the presentation mode, which for some reason is not transmitting.
Which is fine. Let's go ahead.
Yeah, let's go ahead this way. So so I'm going to talk about the relationship between diabetes, heart, and related rhythm disorders. We deal with quite a lot of rhythm disorders, particularly in my field, and a number of them have diabetes and related disorders. But what I was mentioning was that we shouldn't see diabetes as a single entity. It is a mixture of number of other entities, and together they make the relevance of various rhythm disorders important. So my initial slides are to take you through probably what you heard in one of the recent talks about coronary disease, because that is by far the most important reason for fatal rhythm disorders. So I will give a brief overview of coronary disease and then take you through the common disorders, rhythm disorders that we come across. So this is just to show you, just to revise essentially how the heart looks like and what the circulation around the heart is. So if you see, can you see my slide on this? Hello, can you all hear me?
Yes, we can hear and see.
And you can see, yeah. So this is the heart, and what we are seeing here is, sorry, beg your pardon, there are a number of things that pop up. What you're seeing here is a cut section of the heart, and the lower chambers are called the ventricles. We have a right ventricle which pumps through this blue colored vessels into the lungs. You have the left ventricle, which is the main pump, and to the body, that is that supplies the forward flow through the aorta, which is color-coded red. What you also see here is are the two top chambers, which are the atria. I just want to point out these two little blood vessels. If you can see my cursor, these two little blood vessels here, and there will be two which are hidden behind here, are called pulmonary veins. And right now, just remember what these are. They will become relevant later on when we talk about rhythm disorders. So these are the veins which are returning purified blood from the lungs into the left top chamber. The top chamber then transfers the blood into the lower chamber, and then it's pumped out through the aorta to the body. Then it returns through this blue blood vessel into the right top chamber, and then goes into the lungs. Heart is supplied. Heart has to supply all the body. It has to supply itself, and as you know, as the aorta comes out of the heart, it gives branches which are called coronary vessels, which supply the heart muscle itself. And typically, you have the three large coronary vessels, and then several branches which supply the entire heart. Now, what causes cardiovascular disease in diabetes? Now, and what is cardiovascular disease in diabetes? So both type 1 and type 2 diabetics are prone to cardiovascular disease. We'll see in subsequent slides what causes it. What are the reasons why diabetes causes cardiovascular disease? People with diabetes are more prone to have heart attacks. They are more prone to have strokes, high blood pressure, and heart rhythm disorders. Diabetes affects the entire vascular system of the body. As you're aware, people with diabetes, they commonly have other vascular problems. For example, peripheral vascular disease affecting blood vessels in the legs, which is even worse if a person smokes. The effect is even more pronounced. It can affect the blood vessels around the eyes, leading to retinopathy. Same blood vessels, if they are affected within the kidneys, they can cause kidney impairment. And the little minor blood vessels which supply the nerves themselves, if they're affected, it causes neuropathy. So in essence, all these things that we see is the effect of diabetes and the related disorders on the blood vessels. And these blood vessels that begin to dysfunction, small clots appear, small obstructions appear, they are less compliant, and hence the damage to the organs, what they are supplying. The fact is that by the time one has a diagnosis of type 2 diabetes, more than 50% of the time, a cardiovascular problem is already there in place. So usually, a number of people with diabetes will not have any symptoms until, and often diabetes is diagnosed when it comes to light, when a person presents with a different disorder. So it makes it very important to identify diabetes in the first place and treat it right at the beginning to prevent these disorders. I picked these slides from British Heart Foundation. They are easily available if you go on BHF fact-finding page of cardiovascular disease. This is just to show that what is the impact of coronary artery disease and what are the top 5 causes of death in UK. Of course, in 2020, the top cause was COVID-19. We also have Alzheimer dementia and also vascular dementia as the second leading cause within that period. And as you can see, then you have coronary artery disease, stroke, lung cancer, etc. When we talk about dementia and vascular dementia, again, it's the same process which is affecting the blood vessels supplying the brain. So it is very common for people with cardiovascular disease to have a degree of dementia, which can be very progressive if the disease process is not halted. I don't want to go through this again because you have recently heard from the slides. The key impact of vessel disease, as a result, whether it is a result of diabetes or other risk factors, is heart attacks, which can come in all varieties from minor heart attacks to major heart attacks. It is very important to talk about fibrillation, and this is a ever-increasing problem, atrial fibrillation. This is when the top chambers of the heart, they begin to fibrillate. I'm sure you know someone or the other who has atrial fibrillation. It is very common. 1 in 4 people are likely to have atrial fibrillation, particularly beyond the age of 65. And the incidence of atrial fibrillation increases. More the number of risk factors, higher the incidence of fibrillation. And what we are seeing is an epidemic of diabetes. We know that in the next 20 years, the number of people with diabetes, the prevalence and incidence is going to be significantly high. Childhood obesity is increasing. All these children who reach adulthood are going to have diabetes at an early age. Not just diabetes, it's all high blood pressure, risk of strokes, high cholesterol, all these problems. And because fibrillation is linked, closely linked with these comorbidities, we are going to see a massive explosion in the incidence and prevalence of atrial fibrillation over the next 20 years. And the estimate is that the prevalence of atrial fibrillation is going to double over the next 20-25 years. So, and this is the most common heart rhythm disorder that we come across these days in every clinic, whether it is cardiology clinic or any other clinic. And we'll go through the details of fibrillation in the next few slides. So what are the risk factors which increase your likelihood of developing heart disease and circulatory disease? High blood pressure is a common one. It's important to mention high blood pressure because it coexists in patients with diabetes. People with diabetes have a higher risk of hypertension. The figures on the right hand right side of the slide are just estimate of how many people are diagnosed with hypertension. But we all know that there is a huge proportion of population who's roaming around with completely undiagnosed blood pressure, and they will only present with when a target organ has been damaged. And that's when the blood pressure comes to light. Same like blood pressure, there are a number of patients, several who, who have undiagnosed diabetes. Very important to diagnose these risk factors early to prevent further problems. I'll just go through this very quickly. Other risk factors which coexist with diabetes are high cholesterol. We all live in various areas with air pollution, so that has its own impact. Additional impact comes from smoking. Not to mention, not to underestimate the risks that one has from increasing body weight, obesity. Again, very important in the setting of diabetes to prevent weight gain, and very important to consistently maintain diet and exercise. All that will become relevant in terms of rhythm problems in later on. Now, this is a really interesting slide, and this is from an old paper. And what you see here is, although there are significant advances in how we provide medical care, drug advances, procedural advances, we are gaining control over various diseases. But at any point in time, if you look at this, there is a comparison of people who have diabetes and total overall number of patients. What we see here is that at whatever time frame we select a population, diabetes always doubles the risk of mortality from cardiovascular disease, but in particular myocardial infarction. So if you see on the left hand part of the slide, we are looking into 1962 sort of era, where we didn't even have coronary care units. So yes, there are more number of people presenting with cardiovascular problems, but those who had diabetes, the mortality is always double in comparison to those who didn't have diabetes. When you have more specific cardiac wards where greater monitoring was done, the number of patients were less, but in proportion, again, those who had diabetes still have double the mortality. And we are now living in the time of coronary intervention. They put stents which save lives. So these days how we treat heart attacks is very different from how it was treated 3-4 decades back. And it is not common to see a person succumbing to a heart attack, unless of course things are left too late. And generally speaking, they're taken, particularly in a country like this, like UK, they're taken straight to the cath lab. They have stents if that is possible, and by and large, they are bailed out from the acute event. But still, although the overall mortality is less, you can still see the mortality is double. So you can take any time from the mortality is double in patients with diabetes. And this is another interesting slide where you can see that coronary disease by incidence of HbA1c levels. So higher the HbA1c levels, higher the mortality. Whether you take coronary heart disease or all cardiovascular events. And that's actually no surprise from what we saw in the previous slide. So what causes heart disease in diabetes? And it's a combination of persisting high glucose level or hyperglycemia. And there is a state of fatty acid, circulating fatty acid. And when these combine, when you have hyperglycemia and a state of high fatty acid circulating, it causes what is called endothelial dysfunction. Now, endothelium is considered the largest organ in the body. it can span. I don't know exactly, but I think few football fields. If you lay open the whole endothelial lining, it will be that long. And an endothelial lining is a single cell lining which covers the interior, the inside of all the blood vessels. It is a very dynamic organ. Lot of metabolic exchange happens through this lining. And when there is a damage to the lining, it attracts, in simple terms, cholesterol plaque. The blood vessel becomes less compliant, and hence there is a vascular dysfunction. So and this is what exactly happens. So if you look on the right, this is a cartoon of a blood vessel with a normal lining. When the lining gets disrupted inside, it begins to become rough, and then it begins to attract all sorts of fatty acid. And this, in initial stages, it is called atheroma. In later stages, we call it as the initial stage is called a plaque. In later stages, it's a proper narrowing, which then impinges on the caliber of the blood vessel. And these are again the cut sections. So this can happen, in diabetes. The cause is high sugar levels, circulating fatty acid. People with high blood pressure, there's a direct increase in pressure within the blood vessels, which disrupts the lining and causes the same effect. People who are extensive smokers, the contents of smoke, they cause the same disruption in the lining. So anything that disrupts the endothelial lining will lead to narrowing and furring of these blood vessels, and eventually occlusion of these blood vessels. Just to show that this is an example of a blood vessels which is narrow because it has furred up, and there is a circular rim of a cholesterol plaque which is sitting within this blood vessel. And over the bottom area here, there is a greater intensity of this plaque. And here what you see is that there is a partial rupture of the plaque, whenever the contents which are underneath the plaque, they come in contact with the circulating blood, the tendency of the blood is to immediately clot, because the blood begins to think that there is a break. For example, you break the skin, there's bleeding, and immediately it clots, because that's what the system is designed. So if it feels that there is a break in the lining, it'll begin to clot. So that's a protective mechanism, but in this context, it becomes counterproductive because it then blocks the lumen. So in this example, the person is not going to have a full-blown heart attack, but they may have a partial heart attack, which we call non-ST elevation MI, or in simple, or in lay terms, a small heart attack. Of course, these are precursors of larger heart attacks, and things do need to be done fairly urgently to revascularize this blood vessel. In the second slide, in the second example, we have a total occlusion of the blood vessels. So the plaque has ruptured, and the blood clot has actually occluded the entire vessel, and this person would be in a state of medical emergency, and unless something is done to recanalize the blood vessel within the specified time period, there will be damage to the heart muscle. And again, it all depends what is the caliber of the blood vessel supplying what portion of the heart muscle. The total damage will depend on those factors. Now, moving to some ECGs. So this is an example of a patient who had a total occlusion of the blood vessel. They presented with what is called ST elevation MI, and how we identify, how the ambulances identify these MIs are, this is the typical appearance. The ST segment, which is the portion of the ECG trace between the spike and the next relaxation hump, which is called the T wave. And if that is elevated, that is termed as ST elevation MI. It's a medical emergency, and this person would go in the right setting straight to the cath lab to have stents, which you've seen in the previous talk. So stents, essentially, you put a balloon, squeeze out the block, or often we suck out the block, literally, hoover this area and suck out any fresh clots, because you don't want the clots to go downstream and block the smaller vessels. But so suck out any as much clot as possible, and then leave these stents, which eventually the endothelium, the healthy endothelium, will then eventually line these the stent, and it will be endothelialized in due course, typically within 1 year. And then the blood that flows through the stents will only be in contact with the endothelium, which is lining the stent. Until then, as you know, we have to be on blood thinners, typically aspirin or clopidogrel or a drug called ticagrelor. This is just to show the relative size of stents. And typically during angiography, we look at these blockages, and in this example, this person had a stent procedure to recanalize these blood vessels. Now, this was just to give you a brief idea as to what is happening in these blood vessels and what goes on, if these blood vessels are not revascularized in good time. So what do you think will happen? So suppose this blood vessel is totally occluded. The portion of the muscle that it's supplying will get infarcted, will begin to die. And when the heart muscle begins to die, it throws out various rhythm problems. So that is in the acute context. When the heart muscle sustains a major injury, it has the potential to go into fatal, rhythm disturbances. For the ventricle, which is this is the left ventricle. These blood vessels are supplying, the left ventricle, which you saw in the original picture, the first slide. If the muscle is damaged, it will throw out these kind of rhythm problems. So what we see here is the most fatal of rhythm problems, which we see in the context of acute heart attacks. We also see these rhythm problems when a person has had a heart attack, let's say several years back, and it has caused a permanent damage to the heart muscle. That heart muscle over the years has fibrous, and basically it's like a sheet of fibrous tissue rather than muscle. And those fibrous areas, those what we call as scarred areas, they have the potential to now and again throw out irritant rhythms, which if they are arising from the ventricle, they can be fatal. So in this example, what you see here is if you look at just simply the lower strip, the first 2 or 3 beats are normal because they are thin, narrow complexes. And then you have a train of a few beats which look very, disorganized, big complexes. So they are arising from the lower chambers. And suddenly this person was lucky that you can see that here there are no real complexes, in this portion of the trace, or very, very small complexes. So here the heart is merely just about contracting. It's almost fibrillating the heart, the lower chambers. So while, we see, I spoke about atrial fibrillation earlier. Whilst the top chamber are allowed to fibrillate, and a person will not, may not be even aware of the top chambers fibrillating, the bottom chambers, if they fibrillate, something has to be done absolutely urgently because it cuts off the blood supply. There will not be any blood supply from the heart. So unless something is done immediately, or the fibrillation reverts itself as it did in this example. So just after 1 or 2 seconds, it has gone back into normal rhythm. So the person here may have just felt a little bit of dizziness, and the person was lucky enough at this point in time that it has gone back to normal rhythm. So these are the rhythm problems that we come across when there is acute heart attack, or in patients who have previously had heart attack and the heart muscle is completely scarred. These rhythm problems we also see at the time of successful intervention, and we call them reperfusion arrhythmias. So if a person presents with a completely occluded blood vessel, and that heart muscle is almost dying, and we in the lab we immediately suck out the clot, we put a stent and immediately re-establish the circulatory supply to the muscle. That sudden re-establishment of supply can also irritate the muscle. So it is quite common in the lab setting for a person to go suddenly, immediately after a blood vessel has been reopened, into a stage of these ventricular arrhythmias. So we see these arrhythmias in all these settings around the time of heart attack. This is another example. So this is a person who had these rhythm problems not during heart attack, but this is a person who had a heart attack several years ago and was in a state of heart failure. Heart function wasn't absolutely normal, and now and again he presented with the recurrent dizziness, and when we investigated, when we did various ambulatory recordings, we found this. And what you see here is again a train of extra beats arising from the lower chambers and suddenly triggering this very regular form of tachycardia arising from the lower chambers. So this is an example of ventricular tachycardia, where the chambers are contracting, but they're contracting very fast. And a person may or may not lose blood pressure here. It all depends on what their physical state and circulatory state is at that point. But it won't be long before they begin to feel unwell. And the danger here is that it can degenerate into the previous type of ECG, where there are hardly any contractions. So again, this is also a medical emergency and needs to be treated immediately. This is what I was talking about earlier. This is what is called ventricular fibrillation. So if you see, in comparison to this ECG, where these are normal contractions of the heart muscle, these are abnormal contraction of the heart muscle, but still the muscle is contracting, so it's still capable of providing some output. Whereas here, the muscle is just merely fibrillating. So there are no effective contraction of the muscle. And a person cannot be conscious when this happens, and has to be urgently defibrillated. So we need to shock the heart out from this. Again, when people collapse, out, let's say on the road and somewhere in, outside the hospital, the most important thing that can be done in this setting is bystander CPR. So if a person is collapsed, there is no pulse, the most important thing to buy time before ambulance arrives is to simply provide chest compressions. And that can actually save somebody's life, because the heart may not be contracting, but simply compressing the chest at that point could provide that vital output from the heart to to reach the brain. And it is the brain which is the most important in the first few minutes. All other organs take much longer to have permanent damage, but the brain can get permanently damaged within minutes. So that is something to bear in mind. If there is a person who's collapsed, we don't know what is happening to the heart. But if there is no pulse, it is, or the person is unconscious, not breathing, those few chest compressions can be life-saving. So when people present with these rhythm problems, whether it is ventricular tachycardia of this sort or ventricular tachycardia of this sort, which is arising from many areas, we call it polymorphic, or when they present with the most dangerous event, which is ventricular fibrillation and cardiac arrest, they will almost certainly need some kind of protection, once the immediate situation is sorted. And typically these people will require what is called a defibrillator. So defibrillator is essentially a different type of pacemaker, which has the capability of shocking the heart if the heart were to go in those kind of dangerous rhythms. And we implant these commonly. The devices which are available could be just a simple defibrillator, and I'll explain what it does. Or it could be also a more advanced type of device where you have an extra wire that sits on the other side of the heart, and it tries to make the heart contract a little better. So they are called cardiac resynchronization devices, which have the capability of defibrillating the heart or shocking the heart, and in addition have the capability of making the heart contract better, i.e. synchronizing the contraction of the main chamber. Because when people have had a heart attack, when portion of the heart muscle is not contracting well, so you can imagine that the overall contraction of this cylindrical chamber will be very dysynchronous or out of symmetry. One portion will contract earlier than the other portion. And when that happens, it leads to a state of heart failure or a poor or ineffective output from the heart. So when we find evidence of dyssynchrony or asymmetrical contraction, then we park another wire on the outer surface of the heart. Again, it goes through a little blood vessel which is within this chamber and which leads us to the outer part of the heart. So you can imagine that this is a chamber. One wire is sitting on this side of the wall, on the right hand side. One wire has gone behind the heart and sitting on the outer part of the wall on the left hand side. And then these talk to each other through the brain, which is the actual device, and the timing cycle is set so that the heart actually contracts more synchronously. These are common devices. So when we see people with heart failure and there is evidence of dyssynchrony or asymmetry, we are likely to implant a device which has capability to synchronize the heart function, and that generally in 70-80% of people it leads to significant improvement in symptoms and also reduces their risk, because if the heart is contracting better, it is happier, and if the heart is happier, there is less likelihood of the chamber going into those kind of dangerous rhythms you saw earlier. Coming back to what a defibrillator is, so we implant it through a blood vessel here. The wires are there. You can just about see these shining white sort of coating on this lead. So there's one here, there's one here at the bottom part of the lead. On the X-ray, you see it as a more darker or more shinier or more radiopaque, this whiter looking part of the lead. Now this is a coil. So this is basically a coil that is wound around the surface of the lead, and it is this coil that provides the shock. So that shock actually travels through the heart, and the circuit is completed when it reaches the box. So the box is part of the circuit. So the current is delivered through the wire. The current exits through this the coil. It goes through the heart and then completes the circuit by going back into the box. So you could have a shock, from the coil which is lying in the top chamber, or you could have a shock that is from the coil in the lower chamber. Typically, we implant. The coil in the lower chamber is important. You need that coil. And that shock, most shocks will terminate the heart, whatever rhythm the heart is in, and then when the heart restarts, almost always it restarts with its own normal rhythm. So this is the function of a defibrillator, and the shock is quite strong. Some people describe it as a kick of a horse, but it is a life-saving shock. Now, when we implant defibrillators, when we have seen those kind of rhythm problems, we don't just forget that, okay, we have implanted defibrillator, that's done. The root cause we have to prevent. So defibrillator is there to shock the heart whenever the heart goes into those rhythms. But in the first place, we have to prevent the heart from going into those rhythms, and hence a person will be typically on a set of medication that reduce the chances of those rhythms occurring. But should they occur, there's a defibrillator there, which is sitting just like an insurance policy to shock the heart. So I've just described the rhythm disturbances that we see in the setting of acute heart attack, very common in patients with diabetes, not a direct relationship to diabetes, but by way of the diabetic process causing damage to the blood vessels and then leading to heart attacks, and then leading to these kind of rhythm problems is the relationship here. What we now commonly see on a day-to-day basis is this, which is problems with the rhythm problems of the upper chamber. And I'm sure you know someone or the other who has atrial fibrillation, and it may or may not require treatment because again, it depends if atrial fibrillation is causing symptoms or if atrial fibrillation is leading to heart failure. Only then, it may require aggressive treatment. What we see here is two common varieties of rhythm problems arising from the top chambers. If you look at the cartoon here, this is an example of atrial fibrillation where the top chambers, just like I discussed about the lower chambers fibrillating, the top chambers are not contracting effectively, they are merely fibrillating. And this occurs due to a highly disorganized set of wavelets and daughter wavelets colliding and recolliding with each other. It's a highly disorganized activity that is happening inside the top chambers. And that shows up on the ECG, which you see in the middle strip. And this is a classical example of atrial fibrillation. How we identify this is, and this is how, the common Fitbits and common smartwatches are capable of identifying atrial fibrillation. What their algorithm is identifying is, if you see the top strip, which is the strip of a normal heart rhythm, you see these little humps just where my cursor is. That little hump is a normal hump from a normal atrial contraction. Then it leads to the spike. The spike is the contraction of the lower chamber, and then the big hump that follows the spike is the relaxation hump. The lower chamber is relaxing, and that is a normal ECG complex. In atrial fibrillation, as you can see here, there is no initial hump, and you see a very fibrillatory baseline. You can see the fine fibrillatory undulating baseline just here between these complexes. So when you lose this initial hump, which is the P wave, which is from the contraction of the top chambers, you get this fibrillatory baseline. So that's one important, hallmark of atrial fibrillation. The second hallmark is because the rhythm here is so disorganized, it is bombarding the fibers which are taking the impulse to the lower chamber in a very irregular fashion. So the lower chambers are now contracting in a highly irregular fashion. So all these spikes you see, they are very irregularly placed. There is no pattern here. So there's a greater distance here, there's a smaller distance here, there's a slightly greater distance here, and so on. There is no real pattern. So when a person has irregular heart rhythm, and on the ECG, when we don't see this little hump, that is the diagnosis of atrial fibrillation. And that is how the watches are now capable of diagnosing atrial fibrillation. There's a cousin of atrial fibrillation, which is called atrial flutter. And flutter arises from the right top chamber, the typical variety of flutter. We have different types of flutters, which are called atypical variety, but the common variety or the typical variety is the flutter that arises in the right top chamber. And flutter is a more organized rhythm than atrial fibrillation. But what is happening is, just like you saw in ventricular tachycardia, if I take you back in a few slides, how the ventricles are going into a very rapid but a fairly organized rhythm of their own. Similarly, the right top chamber goes into a highly rapid but organized rhythm. So what you see here is that if you compare from the top slide, where the normal heart rate is one beat here, and then the next beat here, then the next beat here, then the next beat here. Here, there are back-to-back beats. So it is organized because it is contracting, but it is very, very rapid. So the top chambers are going 1, 2, 3, 4. So here, they are contracting at the rate of around 300 beats per minute. But you see, the lower chambers are not going as fast. For every 3 or 4 beats of top chambers, there is one contraction of the lower chamber. So the person's heart rate is actually quite slow. It's about 70, 80 beats per minute in this example. The person may not even be aware that they have atrial flutter in the background, because symptoms predominantly arise from what the lower chambers are doing. And that happens because we have a protective gateway, which is called the junction, which is a group of tissue called the node, the AV node, that governs how many impulses it wants to supply to the lower chamber. And drugs like, all the heart rate reducing drugs like beta blocker, digoxin, Adizem, etc. You may have heard these names. They actually work on this node, make it even more sluggish, to prevent, as many impulses going down to the lower chambers, and hence they regulate the rate of the lower chambers. So this is a good example of flutter, which you see in the baseline. I mean, we teach students, and commonly it is called, oops, what happened here? So my slide has suddenly vanished.
And the slide decided it's getting too late, maybe.
Is it time limited?
No. That was just a bad joke.
I'm not sure actually what happened here.
How many more slides did you have, Abhay?
Just few,
Okay.
5, 6 slides more.
Do you want to just stop?
Just going back, how do we prevent atrial fibrillation? It comes down to the same principles. Lose weight, control blood pressure, control diabetes. There is a state of inflammation in the blood vessels. Remember, I mentioned about endothelium. So the interior of the heart is also lined by endothelium. So if the top chamber's endothelium is unhealthy, it will lead to atrial fibrillation. So, and we see atrial fibrillation now in even younger individuals who are obese, because fatty deposits are occurring on the outer surface of the top chambers, which lead to atrial fibrillation. Why is atrial fibrillation so important? Because it leads to stroke. And strokes in atrial fibrillation carry a very high mortality. There are big chunks of clots that are released from the heart. And when they end up in the brain, the stroke is far more disabling than a stroke that occurs without atrial fibrillation. The importance of exercise cannot be underestimated. There are a number of research papers now which clearly indicate that even if you're doing moderate activity, it reduces your chances of having atrial fibrillation. It increases the outcome of any ablation that we are doing, and prevents further development of AF. And again, it comes down to the same principle, controlling diabetes, controlling high blood pressure, staying active, reducing body weight, controlling cholesterol, comes down to the same few principles, whatever, pattern of common disease we are dealing with. A quick word for how we treat atrial fibrillation. We treat atrial fibrillation, if it is symptomatic or causing heart failure, by way of medication or what is called ablation therapy. And this is just to show what ablation means. Commonly, atrial fibrillation arises from, remember, if you, just to remind you, when I showed the first slides, the blood vessels which are returning purified blood from the lungs into the top left chamber, which is the left atrium. We have identified that there are triggers, sensitive areas which reside in these blood vessels. And in given circumstances, they throw out lots and lots of extra beats into the top chamber. And these flurry of extra beats puts the chamber into fibrillation. So what the basis of ablation is to create barrier of scar around the mouths of these blood vessels. And when those scars are well established, they act as electrical barrier. So even if the inside of the blood vessel is trying to throw out these flurry of extra beats, they are electrically limited by the scars. So what you see here is this bright catheter is trying to cauterize a circle around the mouth of these blood vessels. So that is what is called ablation. It is simply a process of cauterizing the endothelial lining, disrupting the endothelial lining. And when it is disrupted, when healthy tissue is disrupted, it heals with scarring. So we want to create a circle of scar around the mouth of these blood vessels, which will act as a barrier. And in patients who have otherwise healthy atrium, but only this mechanism, this process is very effective. So we can do that by this technique, which is called radiofrequency ablation. We can also do it by putting a balloon. So this is just a diagrammatic representation of the top chamber, which is the left atrium. You can see the blood vessels which are bringing blood from the lungs. So 2 on the right side, 2 on the left side. The balloon occludes the mouth of the blood vessel, and the rim of the balloon freezes to -40, -50 sort of temperature. And that freeze creates a circle of scar around the mouths of these blood vessels. So there are different ways to create the same thing. And this is how it looks like. So these are complicated diagrams, but just imagine we are looking at the top of the chamber from the top surface. These are the big blood vessels joining the chamber, and these are the scars that we have created around the mouths of these blood vessels. If there are other areas where atrial fibrillation takes origin, then we further compartmentalize the chamber by creating what is called a roof line or a floor line, simply compartmentalizing the chamber. This is just to show that where clots occur in the heart, and I hope it runs, yeah. So what you see here is, so this is one of my patients. So I've gone into the left upper chamber and I'm injecting a contrast dye. And my idea was to take a good picture of this chamber, but it has incidentally filled this little ear-like structure, which is called the appendage of the left atrium. And you can see it's a finger-like structure. When the chamber fibrillates, blood clots in this chamber. Now that clot has more chances of occurring if one is diabetic. So if you're diabetic, if you have had a stroke before, i.e. other vascular problems, if there's a heart attack before, heart failure, age over 65, age over 75, they all have their own, score. And particularly in the setting of diabetes, because there is endothelial dysfunction, there is a greater chance of blood to clot within this little appendage. And as long as it stays within the appendage, it is okay. But if it has to release or thrown out from the appendage, it will go into the lower chamber, and that will pump it into the aorta here, and then often it ends up in the brain. So when one has diabetes, it is very important that if there is atrial fibrillation in the background, to be on a blood thinner. Just to show what, this is an example of, again, same patient. Here I'm occluding the blood vessel with a balloon, and this balloon will freeze to -40, -50, sometimes even lower temperatures, by creating a scar around the mouth of this particular blood vessel. So this is what goes on when we try and ablate the left upper chamber to prevent fibrillation. And this is typically what our cath lab looks like. A lot of complicated equipment. This is the same cath lab where we do our work for heart rhythm disorders. This is the same cath lab where the coronary work is done to open the blood vessels during acute heart attack. So same, set of common equipment. For electrical work, there is this extra equipment here.
Just out of interest, is that at Epsom or is that St. Helier?
No, I think this is St. George's. Epsom is not that complicated. It's a very simple cath lab.
I was about to ask, knowing the Epsom hospital.
I'm trying to make it that complicated. I've not yet achieved that at Epsom, but this is actually, this is not St. George's either. I was working at Liverpool. Doing some extra electrical, sort of experience there. So I took this picture of the cath lab in Liverpool. That's it's Liverpool. The number of patients there are far more than what an average London hospital attracts in this hospital. So they do the highest number of AF ablation. That was the statistics when I was there. Across UK, and it was the second highest center in Europe at that time. I'm talking 5-7 years back. So yes, I remember this is a cath lab from Liverpool, but all cath labs will appear similar. This is the anesthetic trolley that sits here, because majority of our procedures, which are ablation procedures, we perform under general anesthesia. We can perform some of them under local anesthesia. So the anesthetist will sit here, and that is if I don't want you to be in the cath lab at any point. No. So let's hope that never happens. You all stay very, very healthy. Just to move on, how do we prevent cardiovascular disease? Again, it comes down to the same basic principle. Moderate activity, at least 30-40 minutes of brisk walking, that's good enough. Control, your carbohydrate intake, dietary, control blood pressure is very, very important. Give up smoking, control the diabetes, control cholesterol, and whatever, whichever disease you talk about, in common terms, it comes down to these factors, because all diseases, as I mentioned earlier, they are closely linked. All common diseases, all cardiovascular problems are closely linked with each other. So when we see a patient with atrial fibrillation, we are not just thinking of atrial fibrillation. We are thinking of what is there in the background, why atrial fibrillation has occurred. So there's no point just simply treating fibrillation or any other heart rhythm disorder, because there is a lot more in the background that we need to control. Otherwise, you can't get on top of atrial fibrillation. And nowadays, the key concept is strongly towards prevention. So before we were aggressively, treating atrial fibrillation with, all sorts of things. Now we are doing all that, but at the same time, providing very strong advice to prevent, further atrial fibrillation. So if I see a person who's obese, or who has diabetes, or who has high blood pressure, or who is smoking, who has not yet had any cardiovascular problems, but we can foresee that, this person has a high chance of developing these. And so if I have to prevent atrial fibrillation in this person, I would be asking them to do exactly these kind of things. Control blood pressure, be active, etc., because that is what is called upstream therapy, directed towards primary prevention. Just a brief word on cholesterol, if you have any questions. Cholesterol above 5 carries a higher risk of endothelial damage and cholesterol plaques developing within blood vessels. And these are general targets. I mean, there are stricter, targets. You need LDL below 1.8, but generally this is what we want to achieve. In practical terms, a cholesterol closer to 4 and LDL levels, 2 or below is in general terms. And finally, we just to revise you, the targets of blood pressure control. Remember, many times the targets in primary care and within the national framework are different from the actual, what the blood pressure really needs to be. And that is a balance between cost effectiveness and what is good enough to achieve to prevent cardiovascular disease. And over the years, these targets have become stricter and stricter. And particularly if there is diabetes, the target is lower. So a proper blood pressure is 120/80. That's we've read it right from school days, and that still holds good. So any blood pressure above that, even though we begin to accept 135/85 as normal, there is a slight element of hypertension there. So the lower the blood pressure, closer to 120/80 is what one in reality needs to achieve. And we shouldn't be satisfied with a home blood pressure value of 140/90, which may appear reasonable, but as you imagine, there is a slightly or certain pressure within the blood vessels, and eventually, even though at a slower rate, eventually it will begin to cause endothelial damage, and then everything begins after that. So the recommendation is that everybody should keep a record of blood pressure measurements at home. And if we control these factors, then we are I mean, if I'm talking from my heart rhythm, side of things, heart rhythm hat, then I'll be directing people to check their blood pressure, make sure it is well controlled. We often pick up high blood pressure and diabetes when we see various kind of rhythm problems. What I haven't shown is the common palpitations, what people experience, and clinics are full of people presenting with ordinary palpitation. I feel fluttering sensation, I feel missed beats, extra beats. And you have to think that why these are occurring, because there is certain unhappiness, with the heart. So if it is needing to contract against the high blood pressure, it will throw out extra beats, which may occur only for a few seconds, but they are giving us a very important clue. Same thing happens and these extra beats can arise from the lower chambers. They can arise from the upper chambers. Often these are dismissed because they are in reality benign, but we must look a bit deeper, that if they are occurring, are they occurring truly for benign reasons, or do we need to dig deeper and see what is the state of the internal metabolic environment? Is there borderline diabetes? Is this person heading to diabetes? What is the state of blood pressure, etc. So this is how one thinks in the clinic when we come across these rhythm problems. And that is my last slide. What I would encourage you to go is on these website, which is Arrhythmia Alliance website. These are the best charities in the UK, and they give very useful pages on cardiovascular, in simple English, cardiovascular prevention, arrhythmias, if you have atrial fibrillation or other rhythm problems. Really good website. So Arrhythmia Alliance or Atrial Fibrillation Association, if you need to know more about atrial fibrillation. So these are the best two websites I would recommend. Also, in our local area, please join Surrey ASG. You can just Google it, and it'll link you with this email. If you email, we provide like your platform, we provide once every month educational talks, inviting various speakers, predominantly on heart rhythm disorders. So please join. And that is truly my final slide. Sorry about the hackers disturbance in between. It was a bit of enjoyment in between, though, seeing Guns N' Roses.
It could have been worse. So
yeah, it could have been worse. At least this was a fairly sober hacker.
Correct. I think it was still fairly civilized. So, but nonetheless, yes, it was. What a nuisance. So hopefully,
yeah, it is a nuisance. Frankly, I've heard these things happening, but I've never experienced this. Is my first time.
It's the same. Likewise, I've never experienced this, and yeah, slightly disturbing. But look, this has been so entertaining and informative, Abhay. So thank you very much.
Let me stop sharing, and I'm ready to take questions. I'm in no hurry, so I can take as many questions as you like.
Yeah, and I think, look, we overrun slightly, but I felt it was the right thing to do, given how fascinating really your presentation has been. So let's just open up for any questions. I think Rose.
Yes, may I ask a question? One of the slides, the